Hello, I'm Dr. Anthony Wheeler, and I'm telling you everything that you need to know about pathology. Now, you might be familiar with this image and all these symptoms. You'll see this clinically. Smell that acetone breath. Note the weight loss. Yes, classic signs of diabetes. We're going to be discussing this and much more in this presentation on pancreas pathology. This is covered in your book, Medical School Pathology and Step 1 Review. You can scan the QR code to get to the updated material, as you know, because you're ahead of the game. Now, pancreas pathology is very high yield, and we're going to be discussing the important things that you need to know. Annular pancreas, acute pancreatitis, chronic pancreatitis, pancreatic carcinoma for sure, obviously the types of diabetes 1 and 2, and pancreatic endocrine neoplasms. So here we can see an image of the pancreas, right? Don't disappoint me now. You recognize that anatomy? We'll see. The exocrine pancreas is responsible for secretion of ions, water, and digestive enzymes such as what? Pepsin, right? Pepsinogen, whatever, into the duodenum of the gastrointestinal tract. Here we have imaging from a cyst associated with the pancreas, as well as pancreatic tissue showing endocrine and exocrine features, as well as ectopic pancreatic pseudocyst and a cyst presenting as a cervical and mediastinal mass. Do you recognize the histology there? You see the acini? Now, you know this imaging, right? Normal pancreas on an ultrasound. You can pick this up. Speaking of which, you know the pancreas is not only exocrine but also endocrine. So the endocrine pancreas actually consists of groups of cells known as islets of Langerhans. You're going to be asked about that for sure. Each of the several cell types that make up an islet produces a different type of hormone, right? Insulin is secreted by beta cells, which lie in the center of the islets. In skeletal muscle and adipose tissue, where glucose absorption by GLUT4 lowers blood glucose, they are a key anabolic hormone that actually upregulates insulin-dependent glucose transporter protein, which is GLUT4. Increased glucose uptake by the tissues leads to increased glycogen synthesis, protein synthesis, and lipogenesis. Aren't you glad, you expert in biochemistry, that you get to utilize that knowledge? It never goes away. It's always going to show up. Alpha cells release glucagon, which competes with the insulin to raise blood glucose levels in conditions like fasting by causing glycogenolysis and lipolysis. And what's an annular pancreas? Well, that is a developmental abnormality where the pancreas forms a ring around the duodenum. A potential complication of an annular pancreas is duodenal obstruction. Here we can see a CT scan showing a coronal image and the portal vein where this pancreas is indicated by a dotted arrow, showing the retroportal part of a circumportal pancreas. Interesting. You know what's more interesting? Acute pancreatitis, because you will be asked about this, right? This is a high yield topic. Acute pancreatitis occurs when the pancreatic parenchyma is autodigested by pancreatic enzymes. The result is acute inflammation and bleeding of the pancreas. To the right here, we can see on ultrasound acute pancreatitis occurring. To me, that just looks like a lot of fuzzy white dots. Maybe some of you future radiologists can pick this up. It's highly unlikely that you will ever see this image if you're not going into radiology. And it's highly unlikely that this will present on any sort of examination without a good clinical scenario or vignette where you would obviously know what the diagnosis is, right? And you're going to need to know the enzymes too. That's important, especially trypsin. Trypsin that is activated too early causes the other pancreatic enzymes to also become active. Trypsin actually causes the peripancreatic fat to become necrotic and the pancreas to experience liquefactive hemorrhagic necrosis. In fact, the most important risk factors for acute pancreatitis are gallstones and alcohol consumption. So the next time you're out on a Thursday, Friday night, remember that. Speaking of which, you're parlaying on various recreational activities. I get smashed are risk factors for acute pancreatitis. And what does that mean? Well, let's break it down here. Idiopathic causes, gallstones, as we know, ethanol, as you know, trauma, steroids, right? Mumps and malignancies. Autoimmune conditions are associated with acute pancreatitis. The rare scorpion sting for my friends out in Vegas. Hypercalcemia and hypertriglyceridemia. Endoscopic retrograde cholangiopancreatography, which is a procedure to get to the pancreas to remove stones from that region, as well as drugs. I get smashed. Drugs that are known to cause acute pancreatitis include, importantly, hydrochlorothiazide. That one shows up a lot. Yes, it does. Hydrochlorothiazide. Don't say I didn't tell you. As well as azathioprine, Bactrim, pentamidine, and didanosine, whatever that is, right? Anyhow, clinical symptoms that you must be aware of for acute pancreatitis are nausea, vomiting, periumbilical and flank hemorrhage, and epigastric stomach pain that radiates to the back. You often find this on clinical vignettes that are trying to hint at either MI, some sort of aortic tear, or myocardial infarction. A key differentiator would be elevated serum lipase and amylase, where lipase is more specific for a pancreatic injury, as well as the hypocalcemia that results when calcium is consumed during saponification, and fat necrosis may also occur, right? And some complications of acute pancreatitis include a pancreatic pseudocyst, shock, disseminated intravascular coagulation, also known as DIC, acute respiratory distress syndrome, rupture, and a pancreatic abscess. And since we're on the topic of disseminated intravascular coagulation, what sort of leukemia that you treat with all-trans-retinoic acid is also associated with DIC? Acute promyelocytic leukemia? Yes, you remember those hour rods. Don't disappoint me. Now, E. coli usually causes pancreatic abscess, which manifests as stomach pain, a high temperature, and persistently increased amylase. Now here we have imaging from a CT showing acute exudative pancreatitis with extensive fluid collections that even I can see. I'm a pathologist. I don't look at these black and white images like you future radiologists. But even I can see this. If I can see this, guess what? Test makers, I want you to be able to see this. So have this image in your mind. And here we have a cartoon showcasing a still shot of a pancreas showing acute pancreatitis, likely caused by this blockade here. And here we have various panels showcasing a well-circumscribed mass in the pancreas body that was observed, and some histology was taken from it, showcasing proliferation of pancreatic parenchyma. This is very interesting. This is a solid pseudopapillary neoplasm of the pancreas. So keep that in mind, right? In real life, it's highly unlikely that you'll see this combination on a clinical vignette scenario. But for real life, always remember that multiple entities that can occur at the same time. Now let's move on, switch gears a little bit here and discuss chronic pancreatitis. Chronic pancreatitis is the fibrosis of pancreatic parenchyma. The most common cause of chronic pancreatitis is recurrent acute pancreatitis. And some clinical signs of chronic pancreatitis that you must know include back radiating epigastric discomfort, pancreatic insufficiency, malabsorption, steatorrhea, right? You remember what that is, right? Like very fatty stools floating on top of the water. Ugh, I don't want to imagine that. Deficits in fat-soluble vitamins, right? Because if you're not absorbing the fat, it's highly unlikely that you're absorbing the fat-soluble vitamins. So their A, D, E, and K will be low. And guess who's going to have coagulation issues probably? 2, 7, 9, 10, protein C, protein S. You remember that? I know you do. Also associated with chronic pancreatitis, lipase and amylase are inefficient serologic indicators of the chronic pancreatitis, right? So keep that in mind. Imaging of chronic pancreatitis typically shows dystrophic calcification of the pancreatic parenchyma. And chain of lakes, that's a buzzword, chain of lakes appearance brought on by pancreatic duct enlargement. The consequences of chronic pancreatitis include diabetes mellitus, right, because of the insulin issues, as well as pancreatic cancer. To the right here, we have various panels showing various issues associated with the pancreas. We have a normal, non-disease control. We can see mild pancreatitis in the top right, severe pancreatitis in the bottom left, and the pancreatic ductal adenocarcinoma in the bottom right. Speaking of that, let's discuss pancreatic carcinoma. This is important. Pancreatic carcinoma is classified as an adenocarcinoma that arises from the pancreatic ducts and is most frequently observed in older patients who have an average age of about 70 years old. To the right here, I want you to keep this in mind. This is histopathology of a particular type of adenocarcinoma of the pancreas. This is specifically an adenosquamous carcinoma. Note that the tumor has components of both malignant glandular adenocarcinoma, as you can see, more so on the right, and squamous components, more so on the left, that nested appearance. And like you already know, major risk factors for pancreatic carcinoma are smoking, no surprise there, as well as chronic pancreatitis. Typically, clinical symptoms of pancreatic carcinoma show up later. And those symptoms include epigastric pain, weight loss, and even obstructive jaundice. The clinical signs of pancreatic carcinoma also include pancreatitis and the so-called Trousseau sign, which is migratory thrombophlebitis. In approximately 10% of individuals, actually, they show up as erythema, soreness, and edema in the extremities. And the serum marker, the serum tumor marker that is, for pancreatic carcinoma, which is CA19-9, is increased. Pancreatic carcinoma, for you future surgeons, is treated by surgery, particularly this procedure that's very well known. It's very complex. It takes a long time, called the Whipple procedure. Through the Whipple procedure, surgery, the head and neck of the pancreas, the proximal duodenum, and the gallbladder are all removed together during this elaborate surgical resection. Pancreatic carcinoma has a very poor prognosis, and the 1-year survival rate is less than 10%. To the right here, we can see the histopathology of acinar cell carcinoma of the pancreas. And to the right here, we can see pancreatic ductal adenocarcinoma in various panels here. The top left is the gross slice. B is the H&E. And then we see various immunohistochemical stains in C and D. And this is immunohistochemistry showcasing various immunostains highlighting pancreatic carcinoma tissues and paracarcinoma tissues. Now let's move on to a highly tested topic known as diabetes mellitus type 1. You're probably already being asked about this from people that you know, from your family, right? Everybody knows this. Diabetes mellitus type 1 is due to an insulin deficit and the autoimmune destruction of beta cells by T lymphocytes. In this cartoon here, we can see various clinical features associated with diabetes type 1. The blue are the ones that are very particular and more so seen with type 1 diabetes. Type 1 diabetes mellitus is a metabolic condition characterized by increased glycemia. Type 1 diabetes mellitus is characterized by inflammation of islets associated with HLA-DR3 and HLA-DR4. It's interesting because the insulin autoantibodies are a common indicator of damage and may be present for years before clinical conditions even manifest. And clinical signs of insulin insufficiency show up in early manifestations of diabetes mellitus type 1. And when there is insufficient insulin, the high serum glucose causes skeletal muscle and fat to absorb less glucose, right? It's a negative spiral. Unopposed glucagon causes gluconeogenesis, glycogenolysis, and lipolysis, which aggravates the hyperglycemia even further. Symptoms of diabetes mellitus type 1 include polyuria, polyphagia, polydipsia, low muscle mass, and weight loss. Hyperglycemia, that is greater than the kidney's capacity to reabsorb glucose results in glycosuria. So this is a nice question to ask to get that system integration between the pancreas and the kidney, right? Certain people love to ask this question. Osmotic diuresis is caused by the extra filtered glucose. And treatment of diabetes mellitus type 1 involves lifelong insulin use. In fact, there's an increased risk for diabetic ketoacidosis in diabetes mellitus type 1. So pretty soon you're actually going to be on the wards, right? If you're not already. Keep a lookout for this, right? It's something that you can easily do and check to make sure these patients aren't put in increased risk, because this can actually be life-threatening. Note that it is marked by high serum ketones, which frequently develops in response to stressors, including infection and conditions where adrenaline promotes glucagon. Increased lipolysis results in more free fatty acids. And these free fatty acids are then transformed by the liver into the ketone molecules 3-hydroxybutyric acid and acetoacetic acid. Diabetic ketoacidosis results in hyperglycemia greater than 300 milligrams per deciliter, anion gap metabolic acidosis, and hyperkalemia. Diabetic ketoacidosis typically presents with small respirations, dehydration, nausea, vomiting, mental status changes, understandably, and fruity smelling breath due to acetone. Remember to do your thorough physical exams, right? Fluids are administered to treat polyuria-induced dehydration, and insulin is administered, and potassium-containing electrolytes are replaced, right? We want to take care of our patients. Now let's discuss diabetes mellitus type 2. Diabetes mellitus type 2 is the end organ insulin resistance leading to a metabolic disorder characterized by hyperglycemia. Now this is classically more so older patients that are obese or overweight or morbidly obese, but it's becoming more and more common with younger children. With 90% of instances, diabetes mellitus type 2 is thought to impact about 5 to 10% of the US population, and the incidence, as you can imagine, is still on the rise. Diabetes mellitus type 2 is due to the reduced number of insulin receptors brought on by obesity. Diabetes mellitus type 2 typically manifests in middle-aged obese individuals. Early in the condition, insulin levels rise. As beta cell exhaustion progresses, insulin insufficiency eventually appears. Histology of the pancreas in a patient with diabetes mellitus type 2 may show amyloid deposition in the islets. And clinical symptoms of diabetes mellitus type 2 may include polyuria, polydipsia, and hyperglycemia. Diagnosis of diabetes mellitus type 2 is made by measuring blood glucose levels, and you're going to have to know that. The normal blood glucose value is about 70 to 120 milligrams per deciliter. Diabetes, which you must know, is diagnosed by a glucose levels falling within the various states. So fasting glucose that is higher than 126 milligrams per deciliter, or random glucose, which is higher than 200 milligrams per deciliter. A GTT, glucose tolerance test, showing a higher than 200 milligrams per deciliter serum glucose level 2 hours after glucose loading. Or hemoglobin A1C of 6.5% or greater. Treatment of diabetes mellitus type 2 involves weight loss, diet modification, exercise, metformin, sulfonylureas, and sometimes exogenous insulin. Now, there's some potential complications of diabetes mellitus type 2. Specifically and importantly, we need to highlight hyperosmolar non-ketotic coma. Now, consequences of diabetes include non-enzymatic glycosylation of the vascular basement membrane. Also, atherosclerosis and associated consequences are caused by a lack of large and medium-sized arteries. Diabetic patients with peripheral vascular disease have the majority of non-traumatic amputations, while cardiovascular disease is the primary cause of death among diabetics, right? That's what that prior slide was getting at. In fact, high-line arteriolosclerosis and renal arterioles that are involved cause glomerulosclerosis, which results in small, scarred kidneys with a granular surface. Multiple systems are affected. The glomerular hyperfiltration damage caused by preferential efferent arterial involvement actually proceeds to nephrotic syndrome and microalbuminuria as a result. Now, this is important. The histology of the kidney associated with diabetes shows buzzword Chemistille-Wilson nodules in the glomeruli. You'll probably be seeing that in the near future. Schwann cells that myelinate the peripheral nerves, the pericytes of the retinal blood vessels, and the lenses are open to glucose injury and entry. On the other hand, aldose reductase turns glucose into sorbitol, causing osmotic damage. Excess glucose results in peripheral neuropathy, impotence, blindness, and cataracts. In fact, in the developed world, diabetes is the main factor causing blindness. Now let's talk about pancreatic endocrine neoplasms for a bit here. Pancreatic endocrine neoplasms are tumors that originate from endocrine cells of the pancreas. As you can see here to the right, in this pancreatobiliary type of intraductal papillary mucinous neoplasm, which is a malignancy of the pancreas. Less than 5% of pancreatic neoplasms are pancreatic endocrine neoplasms, which are islet cell tumors. Along with pituitary adenomas and parathyroid hyperplasia, they are frequently a part of MEN1 syndrome. Insulinomas appear as sporadic hypoglycemia with altered mental status that is treated with glucose. Blood glucose levels, which are usually less than 50 milligrams per deciliter, are used as diagnosis. Gastrinomas manifest as Zollinger-Ellison syndrome, which are peptic ulcers that are resistant to treatment. Multiple ulcers are likely, and they can spread into the jejunum. And somatostatinomas present as achlorhydria due to inhibition of gastrin and cholelithiasis with steatorrhea due to inhibition of cholecystokinin. Symptoms of somatostatinomas include watery diarrhea and hypokalemia. Achlorhydria are caused by VIPomas, excessive vasoactive intestinal peptide secretion. And with that, you completed a very important presentation. I'm so proud of you. I applaud your efforts. You're doing such a great job. You're going to rock. You know everything. You got this. Keep making me proud. Keep doing your thing. And I'll see you next time.